So now we move on to the second part of the morning session, which is basically going to be case presentations. Dr. Kannan will be the moderator of this session, and the panelists would include Dr. Choi, Dr. Muhammad Nazrul, Dr. Shamrus, Dr. Su, and Dr. Yam. So the theme is investigations for coronary artery disease. When is it enough?
The first patient is a 65-year-old man who was seen on the 11th of April 2019. A few days prior to seeing me, he had been in Manila on a business trip. He had had a few glasses of beer, and his reflux disease, which was known, was acting up. 3 days later, on the plane back home, he was burping a lot. Upon landing, he developed retrosternal compressing chest pain. There was no sweating or dyspnea. The symptoms lasted about 20 minutes, and the pain kept recurring for 2 days. He came to our emergency room. ECG was done while he was still having chest pain. This is the ECG, and I think we're going to get Dr. Nazrul to comment on the ECG.
Hello, hi. All right, so if we look at the ECG here, first thing, it looks grossly normal. But let's look at it individually, right? So if you look at the QRS complexes, they look fairly normal in size and shape. They are at regular intervals. If you look at each QRS complex, it is actually preceded by a P wave. So this would suggest that this patient is in sinus rhythm. Now, in relation to the history of this patient, he's coming in actually with chest pain. So what we want to look for is whether there's any signs of ischemia. So it is generally what we want to see is there's any ST segment changes or any T wave changes. So if you look at these patients' ST segments, they are all normal, right? You don't see any presence of ST depression or ST elevation, and the T waves are also normal in size and shape. So I would say that this patient has got a normal resting sinus rhythm ECG.
So we agreed with Dr. Nazrul. He also had a troponin T test, and this was negative. And as we know, we don't want to be caught with a troponin test if the patient's pain was just 2 hours ago. But this man has been having pain for a few days. So the fact that it was negative was also reassuring after several days of pain. So he was restarted on his proton pump inhibitors and became asymptomatic. The past medical history, he had hypertension, regular treatment, he was asthmatic. 2 years earlier, coronary calcium score was 0. And in March of 2019, that's about a month earlier, he had a treadmill test done by me. This showed mild, what I thought was mild asymptomatic ST depression at peak exercise. Nazrul, see whether you agree with me.
Okay, so just very briefly about the stress test. Yeah? So the good thing about the stress test is it's very convenient. It can be done in the outpatient setting, and you get the answer quite straight immediately. Now, the thing that we're actually looking for in a stress test is we're looking to see whether there's any ST segment changes would indicate ischemia. So a positive stress test is actually determined by the presence of ST segment depression that is either upsloping or horizontal. So if we look at this stress test here, all right, if we look at the ST segments at the inferior leads here, as well as V4 and V5, we do see presence of ST segment depression. But if we look closely, we see that it is actually an upsloping ST segment rather than a horizontal or a downsloping ST depression. So by definition, we would actually say that this patient has got a normal stress test. Yeah? So I would agree with Dr. Kannan in saying that this is actually a normal stress test for this patient.
We're a little suspicious, but we're not too excited. So anyway, in the family history, his younger brother had angioplasty, an uncle had coronary artery disease. His treatment was blood pressure medicine. I won't mention it because it's not our sponsor's drug. Might get thrown out. He was prescribed statins, but he was not regular with statins. Clinical examination was essentially normal. There was a little bit of epigastric tenderness. So now Dr. Shamrus is going to start working. Dr. Shamrus, what are the possible causes for these patient's symptoms, and what are the reasons for your consideration?
Okay, hi everyone. So basically, as per Dr. Kanan's presentation earlier, there are a few major groups that you want to consider. Number one, of course, is heart. Number two, pulmonary related issues. Number three, GI related issues, and other things like musculoskeletal and joint related issues. For me, based on the symptoms and the background, two major groups I would consider at this point is whether this pain is from his heart or from the GI. This would be my two top differential diagnoses.
Okay. So what would you put your money on at this stage, Shambros? Is it his stomach or is it his heart?
Given his risk factors and background, I'm a bit suspicious. I would definitely want to exclude coronary artery disease before assuming this is his long-standing GERD. Because sometimes patients may have GERD for many, many years, but at some point they develop angina, but they still assume that this is GERD-related issues. So I don't like to do this. I always tell my patient, look, you may have GERD before, but now with your risk factors, you're older, your pre-test likelihood is higher, you need to exclude coronary artery disease before assuming anything else.
Okay, thank you. So, Dr. Nazrul, the ECG in the emergency room was interpreted as normal. Does this exclude coronary artery disease?
ECG is not a very good test to when it comes to detecting stable coronary artery disease. It has got very good sensitivity and specificity when a patient comes in with an acute coronary event. So a normal resting ECG would not exclude coronary artery disease, and in the context of this case, we would then suggest the patient to do further non-invasive testing to actually rule out CAD.
Thank you. The troponin T was done in ER. It was normal. So does this exclude coronary artery disease? It's still with you, Nazrul.
Okay, so a TROP-T is a cardiac enzyme, and TROP-T is usually excreted into the bloodstream when there are any cause of damage to the heart muscles. So this can be either due to an acute occlusion in one of the arteries, or it can be due to any cause of inflammation of the heart muscle itself. So in cases where the patient has got stable plaque where they don't come in with an acute syndrome, you may not see an elevation in TROP-T. So I would say that in this particular case, a normal TROP-T would not exclude coronary artery disease, but what it does tell us is that this patient is not having an acute event at this particular stage.
Okay, thank you. The treadmill test was done 1 month earlier and was reported as mild asymptomatic ST depression peak exercise and considered to normal. Still with you, does this exclude coronary artery disease?
Well, the sensitivity of a stress test is 70%. So I think when interpreting the stress test, we have to look at a few things. For instance, the patient's risk factor profile itself. If the patient has got multiple risk factor comorbidities with a normal stress test and we're still unsure as he or she may still be having symptoms of chest pain, what we can do is to actually put the patient on other non-invasive tests, which I think we will be discussing later on. So just to put it into context, a normal stress test in a high-risk patient probably would not rule out coronary artery disease 100%. Yeah.
Okay, thank you. What is the accuracy of a treadmill? I think you've already answered that, yeah? And then maybe a quick response to this. When would you not do a treadmill test? I'll give you some ECGs to help you explain.
Okay, so this is an so this ECG actually shows left bundle branch block. Yeah. So if a patient has got an abnormal resting ECG, a stress test would not be ideal because it would be rather impossible to interpret it. So an abnormal resting ECG would not be suitable to do a stress test. Yeah.
Okay, so the second ECG shows a lot of left ventricular hypertrophy, strain pattern. So it's an abnormal rest ECG to start with. So this is another one where we would not do a treadmill. It's not going to help us. This to Dr. Su. He had a coronary calcium score done 2 years earlier and was measured as 0. Can you tell us what a coronary calcium score is?
A calcium score is done nowadays with a CT scanner. It's actually a very cheap, very easy thing to do. It only uses about 1.5 millisieverts, which is about 2 X-rays to be done. we now are able to do calcium scoring with this procedure and find calcium in the coronary arteries or calcium in other areas like the aorta and other vessels like the carotids as well. Now, calcium found in the coronary arteries derive actually from dead cells, apoptosis, mainly of macrophages and smooth muscle cells. If you find coronary artery calcium in the coronary arteries, it usually alludes to coronary artery sclerosis. However, coronary artery sclerosis does not definitely mean there is calcification. So if you find calcium in the coronary arteries, it suggests that there is actually coronary artery sclerosis present. Now, the higher the calcium score is, it suggests that it carries a worse prognosis from the population studies done. So with a calcium score of 0, it probably indicates there is no coronary artery sclerosis at that point of the arteries.
And okay, and what about a coronary calcium score of 0 in a 65-year-old man? What does that tell you?
This is quite remarkable. At 65, we would want to, with all the risk factors. Okay. With a calcium score of 0 at 65, this is very remarkable. With all these risk factors, we expect to see some coronary artery calcification. In the population studies, we find that compared to the American whites, the Chinese population is actually have a high calcium scores. The calcium score actually is related to not just age, race, sex, and also genetic studies as well. So finding a calcium score 65 in this chap, it suggests that he may not have any coronary artery sclerosis and is very good. However, it doesn't exclude coronary artery sclerosis.
So that's an important point, that as we all grow older, all of us will have some calcium. So if we would do a scan in this hall today, most of us are going to have calcium, except for very young, handsome people like Shamro's probably will be 0. Yeah. So, but to sort of have a score of 0 in a 65-year-old man is actually very good. Huh? So I must say that I got a bit blinded because of that. Dr. Choi, what tests would you do during this clinic visit, which is a day later? Yeah.
So we have here a patient with very non-specific ECG changes during stress test with strong family history of ischemic heart disease. Unfortunately, he has calcium score of 0. For me, I will still do some forms of ischemic study. So for example, we did an exercise stress test, which was found to be slightly debatable. Then maybe I'll extend it to a stress echo. So with the power of echo imaging, maybe they will give us a bit of idea. Alternatively, other types of non-invasive tests like myocardial perfusion scan can also be considered. Lastly, if any doubt, probably I will counsel the patient for a full contrasted CT scan.
Thank you. So the tests that were done in the clinic was, I repeated the ECG, which was still normal, did another troponin test, was still negative. So Dato, would you do any other test?
The problem with the calcium score only in a patient who is symptomatic is that if the patient has a soft plaque, i.e. a plaque without calcium in it, we can miss that. So like Dr. Choi was saying, if we do a CT, cardiac CT with contrast, rather than just a calcium score, that would be one option. But given that this patient has had persistent symptoms, the other option that we could consider is basically an invasive coronary angiogram. So I would have a discussion with the patient about these two options.
Okay, thank you. So I suppose that treadmill is not worth repeating, but it's just done a month ago. And so I think you've already voted for this. I was going to ask you to tell us a little bit about CT angiogram, and this slide to help you explain.
Yeah, basically, in short, we are trying to visualize the main arteries on the left side and the right side with contrast. So in this picture, we can see actually the LAD visualized here, and where the proximal part of the LAD, where it's labeled as non-obstructive plaque, you actually see some very gray areas and some within it some white areas as well. So this looked like about a 40-50% stenosis, and within the plaque you can actually see the gray areas, which suggests atheroma, cholesterol deposits, and also the white part actually suggests the calcium. So that's where you probably got the measurement of calcium score of around 50. And then in the cross section labeled as B and C, you can see similarly the plaque there. So that gray area, and which is highlighted in orange, is where the cholesterol lipid areas are, and the white dot above it, which is also surrounded by green, is where the calcium part is. So what I was saying about calcium score of 0, if you do a calcium score only, which is already a good screening test, if the calcium score is 0, you're unlikely to have plaque. But rarely we do see plaques with just lipid or cholesterol within, and the patient may have a calcium score of 0 still.
Okay. So I think we have explained all this. Let's just move on in the interest of time. So CT angiogram was ordered because of its risk factors, especially the family history. So the CT, this is a real case, not put up, a real case. So the CT lab technician rang as he normally does and said, Dr. Kannan, the patient's coronary calcium score is 0. So I'm going to take a little vote from the members of the panel. How many of you would go ahead with a CT angiogram? And maybe it's easier, how many of you would not proceed with a CT angiogram? So the whole group has voted against me. All of them would go ahead with a CT angiogram. So I was lulled into a sense of complacency. I wasn't very convinced by his symptoms. I was also encouraged by the fact that PPIs and proton pump inhibitors were making his symptoms better. He had a treadmill, which I thought was okay. Calcium score was 0. I said, good. Okay, we won't proceed with the CT angiogram. So the patient went home. 3 days later, he came back with 2 episodes of retrosternal chest pain. This time, the pain was on exertion. He never had that before. He was still dyspeptic. So I told him, I think now we should do an invasive coronary angiogram, but he did not want to do this. He wanted to continue with medical therapy. 2 weeks later, he came back and said, now there's 80% improvement in symptoms. And he said some of his symptoms, he was having some retrosternal chest discomfort at the start of exercise, but this would go away as he continued to walk. He felt that he'd been having this for a few years. Dr. Shamrose, can you explain to us what are these patient's symptoms?
Okay, so this is a very rare incident of what we call a walk-through angina. I think it's about 2% of all angina symptoms. So the mechanisms are not fully understood, but it's important to note this because sometimes it gives you false reassurance, because typically angina gets worse as you do more exercise. But in this kind of patient, if they do a regular kind of workload, either jogging or walking, they will initially feel chest pain, but it will improve as they do more. I mean, some postulated theories due to neurohormonal adaptation issues, most of the time it's related to either vasospasm at the beginning of the exercise, which gets better as they exercise more, or sometimes the recruitment of more collaterals. As your heart rate increases, usually you have more vasodilatation, and then you recruit more collaterals in these patients, so the chest pain disappears as they do more. So it's very rare, but it's important to know about this angina incident.
So it's like vasodilation with exercise, offloading the heart, like what happens when you give nitroglycerin. So it's a natural nitroglycerin. Okay, I'll just move on because I think we need to show another case at least. So I said, okay, I think we should do an angiogram, invasive, and again he refused. He agreed to a CT angiogram. The CT angiogram showed severe stenosis of the mid portion of his left anterior descending artery. This was fixed with angioplasty, and he no longer felt any more symptoms. So some lessons learned: GI symptoms remain a frequent masquerader of coronary artery disease. The history remains very important as a guide in detecting sinister causes in patients presenting with chest pains. So even when the calcium score is 0, even in older patients, further evaluation is warranted, especially based on the history.
Hi everyone. So go straight to my second case. This was a 63-year-old female patient, non-smoker, minimal alcohol, non-hypertension and dyslipidemia for more than 5 years. No family history of note. Allergic to NSAIDs. She was on Crestor and Exforge. So she did health screening in June 2022 and was told her resting ECG was abnormal. She proceeded with stress test, but managed to get to stage 2, a bit breathless. No ST changes, but a few PVCs at peak exercise. She did not see any cardiologist at the time. But a few months later, a year later roughly, she was seen in ER for non-related cardiac symptoms, mostly for URTI. She was a bit breathless. They repeated her ECG. Again, was commented, your resting ECG is not normal. Maybe you should go and see a cardiologist for further assessment. So she came to see me in clinic in October for further heart assessment. So history, just a brief one. She denies any chest pain, arm, jaw, back pain, tummy pain on exertion. Just a bit breathless on climbing stairs, but she claims this was long-standing, not new according to her. No other overt symptoms. On examination, nothing remarkable really, normal essentially. Blood test, basic, showed fasting blood sugar was 5.2, LDL 3.1, thyroid function was normal. Other blood tests were unremarkable. So this was her ECG at the time. I'm not sure whether you can see this ECG clearly or not. Choi, do you want to comment on the ECG?
So you look at the 12-lead ECG, my opinion is that there are a couple of so-called abnormal features of the ECG. Look at lead 2, lead 3, and lead AVF, which are the inferior leads. I would say all three of them seem to have Q wave. And I think it's pathological because it doesn't look physiological, involving all part of the inferior leads. And the Q wave also extends over to V3, and a general statement would be a very poor R progression from V1 to V6. So unless this patient has a very different rotation of the heart, this should be considered pathological as well. My guess is she could be having some kind of coronary artery issues, and she might need to be investigated.
So this was the stress test as I mentioned earlier. Nothing much, but the conclusion was equivocal. On the same day, she actually opted for an echo, and the echo was normal other than mild LVH. No regional wall motion, good LV systolic function. That's why, at the time she decided not to see any cardiologist. So what to do next, basically? Continue with symptoms monitoring and risk factors management? Or do you use a different modalities to assess for underlying coronary artery disease? Equivocal, stress test, atypical symptoms, maybe angina equivalent, maybe just a fitness level. So what do we do next? So Dr. Su, do you want to comment about what we've done so far?
I think you've done a quite complete assessment on this lady with risk factors are known for ischemic heart disease, and she has an equivocal stress test. So I would carry on to address the risk factors per se, and perhaps assess her. Previously, if we think it's actually her symptoms is actually on exertion with that kind of stress test, I would recommend further assessment in this case, because as you alluded before in current presentation, ladies have very atypical symptoms as presenting as angina.
Okay. Dr. Kanan, what would you do next?
Like Choi pointed out, this lady's ECG is definitely abnormal. To me, it looks like she has suffered an old infralateral myocardial infarction. I'm very surprised that the echocardiogram is normal. Your treadmill test is equivocal, as we discussed. Treadmill test has got its limitations. So based on all this, I think we need to evaluate she'll need at least a CT angiogram.
Okay, so you would do CT angiogram straight for her. Okay. So basically, she has abnormal ECG, limited exercise tolerance. So you have a few options, what we've discussed so far. Generally, three major things we would consider in clinic nowadays. Either you go for stress echo, full CT with a dye, or nowadays in certain centers you have the option to do stress MRI. In the old days, we do nuclear scan as well. So many options, discuss with the patient, depending on the availability, cost, you can decide about the further assessment. But the point is, she needs further assessment. So symptoms she has, but it's atypical. So in ladies especially, you can get breathlessness, can either be to myocardial ischemia, angina equivalent, or because of LV systolic dysfunction, which she didn't have. So these were the options, like I mentioned earlier. After discussing with her, she opted for full cardiac CTA with dye. And it's actually class 1 indication in patient with intermediate or intermediate to high pretest probability nowadays, according to the ACC guidelines and even our guidelines. So this was her cardiac CTA. It showed, let me just point out to you, a significant near ostial LAD lesion. So, yeah, what do you think? Do you agree with that?
Yeah, I think to be fair, the CT image may be difficult to see, but when we actually look on the system, on the computer, you can see it more clearly.
Yeah.
But this is a proximal significant stenosis. So in view of her so-called symptoms, although you would say it's atypical, then she's also got abnormal ECG, equivocal stress test. There's enough there to suggest that this lesion is definitely significant.
So what would you do next?
PCI.
Angiogram, yeah? Okay. So that's what I advise her to consider. She opted to be referred to other centers to do this. She's still waiting for the angiogram. That's why I couldn't show you the angiogram pictures. So that's my case.
So interestingly, your CT image seemed to indicate the LED area, and there's Q waves over the inferior wall. My theory is that probably her RCA must be very small, so the inferior wall is supplied by other arteries. In her case, probably the LED or the circumflex or LED that wraps around the apex.
Yeah. I think, yeah, you're right. So her RCA was actually non-dominant, and her LAD does have this wrap around phenomenon. So you can see inferior ST changes on ECG. 80% of it is most likely related to RCA lesion, 80% circumflex. Maybe about 2% is related to wraparound LAD. So not all inferior ST changes are related to RCA lesion per se. Okay, yep.
Okay, my case is a case that I saw in clinic. So this is a 52-year-old man who came to my clinic with chest pain. So his chest pain, I would say, is basically atypical. He had some mild breathlessness, but he didn't think it was very severe. Past medical history of dyslipidemia, he's been on rosuvastatin 10 milligram. Otherwise, he's a fairly normal functioning, working professional, non-smoker. So blood pressure was stable. There was fairly unremarkable findings on cardiovascular examination. There was no signs of heart failure. And his blood tests also were unremarkable. Normal full blood count, normal renal function. And I actually checked a troponin because he had chest pain, which was negative. So the other parts of his blood tests showed that he has a mildly elevated cholesterol, even though he's already on therapy. So he was probably slightly higher lipid profile before. And he also had a borderline HbA1c suggestive of impaired glucose tolerance. But this was not known before. So this is his ECG. I mean, when I saw the ECG, I didn't think too much of it. I didn't see that there was any acute changes. But I'm going to ask Dr. Choi to comment on it.
Very interesting ECG. So I agree that the baseline 12 lead doesn't seem to be anything remarkable. The question is, any significance of one PVC that we can clearly see after the 1, 2, 3, 4, 5, 6 on the 7th bit? One single PVC usually doesn't mean anything, in my opinion, unless of course the PVC comes at the very crucial period, meaning that the QT and the coupling interval. So these patients' PVC's coupling interval is at a safe distance. So to me, it looked like a very benign looking PVC, and one PVC alone doesn't seem to carry any clinical significance.
Okay, thanks. So it's not uncommon that we see EGGs with maybe one PVC. So sometimes our technicians will do a rhythm strip to see if the PVCs are more frequent than that. So this is his chest X-ray. So these are the two tests that I arranged from the clinic. We get a lot of atypical chest pain, and all sorts of pathology can occur. So a chest X-ray is helpful, and X-ray basically was normal. So here we have a man with atypical chest pain. ECG X-ray is normal. Blood tests, apart from slightly elevated lipids and HbA1c, unremarkable. Dr. Kannan, if you saw this patient, what do you think you would do?
So I suppose the simplest test to do is at least a treadmill, and if you've got time, do a stress echo, because it'll be more sensitive and specific.
Okay. So I actually did a stress test and echo after that. So the first and second stage, so zero at baseline, sorry, the pre-test and the second stage is actually shown here. There's no ST change. And then this man did quite a good workload. He went into stage 4 on the left there. And also I show the one in recovery. There's no significant ST change. Basically, this is a normal stress test at good workload. He also had an echo which showed normal LV size, no regional wall motion abnormality. EF is normal. So again, we have now more additional test findings. Echo and stress test is now normal. So maybe Dr. Su, what would you do at this point in clinic?
Because he has no further chest pain, and I would just address his risk factors and just follow up. I think that is my normal practice for him at the moment.
Yeah, so nothing controversial, I think. I'm glad I also did the same thing. So I put him on medication, continue to follow up. In fact, at this point, we just kept him on lipids and decided to monitor his sugars. Okay, at this point, he was treated medically, and he had no further chest pain. But I continued to follow him up in clinic, which is as we discussed. But about several months later, he came back and he started to get chest pain again. Okay, so at that point, I discussed with the patient in view of the further chest pain about doing a CT angiogram, because he had already had a normal stress test and echo. So I thought it was a bit weird that he was getting some chest pain. So at this point, we decided to do a CT for the patient. Now, so this is about 6 months down the road where he developed a bit of more chest pain. And we've already shown some CTs, and on this occasion, I could see the vessels quite clearly, but I didn't see any obvious abnormalities on the CT. No stenosis seen. So this is one with contrast. And he had no calcium, 0 calcium score actually. So we've got to the point again, we got some more tests now, another CT in addition. Shamrus, would you add anything at this point?
No, I mean, he certainly should continue with symptoms monitoring and risk factors management. Whether he wants to continue his follow-up with a cardiologist or his own GP, that's really up to the patient. I guess in government, this kind of patient will be sent back to the government clinic for follow-ups, not in the tertiary cardiology clinic. But I always advise my patients, should you have any recurrence of your symptoms, please come back for further assessment. In the meantime, please monitor and manage your risk factors accordingly.
Okay, so again, follow up, no symptoms, and then several months later, he starts to get chest pain again. Now, this time it was a bit worse. This time he says that his pain is on exertion, where previously he had chest pain but was a bit more atypical. So I'll ask Dr. Nazrul, given he had previous normal CT, stress test, and echo, what would you do?
Okay, so the thing that we can note from the history is that the character of the chest pain is a bit different now. It's more severe and it comes on exertion. In view of his risk factor profile, I would definitely urge this patient to get further testing done. I would actually give him the option of either doing a stress echocardiogram if he's keen for it, but I will also offer him a more invasive test like a coronary angiogram for him.
Yeah, so I had a discussion with this patient. At this point, I was very puzzled, and it's a very rare scenario, but this is a real case. And by this time, it was almost a year later already from when he first came. So I discussed with him, and he agreed to do an invasive coronary angiogram. So I did an angiogram, and I was very, very surprised to find that what you can see on the left, he had a very, very short segment, but very severe osteo, so the beginning part of the LAD stenosis. So at that point, it became clear that this was actually the likely cause of his symptoms, and we did an angioplasty to that very short segment. And he improved very much after that. The symptoms resolved. So I think, in summary, this is a bit of an unusual case. A man who presents with initially atypical pain, but the pain got worse eventually. And the initial tests were all fairly unremarkable, including the CT scan with contrast. And then subsequently, the angiogram showed a very short, tight segment stenosis. And in retrospect, what happened was that the CT resolution, I would say, was not showing up the very, very short segment enough to make it obvious. And actually, that was not seen on the CT scan.
We have a bit of questions. Maybe we can address the questions, and then if there's time, we will go on to the last case. Okay? Okay, the first question was, Dr. Kannan, how sensitive and specific is CT angiogram compared to conventional angiogram? Should a conventional angiogram be done prior to decision for stenting CABG?
I think in answer to the question, the sensitivity and specificity of CT angiography is anywhere from about 93% to about 97%, depending upon which study you look at. Of course, as we saw in Yap's case, the final arbitrator is still the coronary angiogram. It's the most accurate test to do. The reason we don't jump and do it for everybody these days, because invasive test is a small risk. I think there's a question about whether angiogram should be done before, what was the second part of the question? Yeah?
Be done prior to stenting CABG.
I mean, certainly, if a patient is being considered for an intervention like angioplasty or bypass surgery, an angiogram is always done, because the CT angiogram is not foolproof. There are errors. Just a quick question, a quick rejoinder to Yap's case. One of the reasons there could have been a change, if either it's a resolution of the CT angiogram, which is not good enough to pick up the lesion, or the lesion may have suddenly developed because of degeneration of plaque within a few days.
Yeah, so history, and again history. Another question, maybe Kannan would like to take it. Will heart score and TIMI score help to assist in deciding the cardiac risk and to decide further investigations?
Certainly. In all patients who see us in the clinic, we'll do a heart score and a TIMI score right at the very beginning. It's part of the assessment of the patient.
What is your view on MINOCA and INOCA? Myocardial ischemia with normal coronary arteries, or ischemia with normal.
This is a big area to discuss. And basically it means that you have got coronary, when you do the evaluation, the coronary arteries are normal, and the patient still suffers ischemia or can even suffer infarction. What is my view?
He has no
It
view.
exists, I've got no
Okay,
view.
okay, we shall go on. And maybe I pass this to Shamrus. What is the advantage of myocardial perfusion scan over coronary CT?
Okay, so nowadays with CT, if you see a borderline lesion, in the past we can't do FFR, but there is an option to do FFR CT nowadays, but it's still very costly and it's not widely available. So the issue is whether this anatomical narrowing is causing ischemia or not. This is always the issue. So invasively, if you're borderline lesion, we do FFR invasively, but non-invasively, if you have borderline stress test or a borderline lesion on CT scan, you want to assess the ischemia burden further, you have the options nowadays, especially in our center, we do cardiac MRI. So you can do stress perfusion cardiac MRI to quantify the ischemia further.
So basically, it is to look for ischemia,
Ischemia.
whereas a CT looks at anatomy.
Anatomical, yes, correct.
So if you see there's an anatomical lesion, but you want to look for assess severity, this is one of the modalities you could use to look for ischemia.
Correct. Yeah.
Okay, this is an important question. Besides diabetes, high blood pressure and high cholesterol, stress has become a major risk factor. See a lot of young MIs in young people who are not diabetic, hypertensive, but stressed at workplace. What are your views of this? Sue, do you see a lot of them?
We do, and patients do ask about what can they do about their stress level affecting their coronary artery disease. However, I find a lot of the times de-stressing, they may actually have some techniques like regular exercise. They may de-stress themselves and have a bonus, a benefit. Other things like smoking is very important in these people who are very stressed. And I would advise them highly against smoking. So stress at workplace is a very important issue, but we try to actually encourage them to de-stress by other kinds of non-pharmacological method.
Yeah, stress is a big thing. You don't know. And often they smoke and they eat bad and they got sugars and lipids all tied together. Now, maybe this one. When do you do an MRI, an MR, CT, and a cardiac CT? Shamrus, would you want to just a quick allusion? That means an MRI or an MR CT versus a cardiac CT. I think this is what we addressed earlier, looking at ischemia with the MRI or looking for viability versus anatomy.
So, I mean, the first question is always, why do you do the test? So nowadays, in a lot of centers, cardiac CT is widely available. And if your pre-test likelihood is intermediate or intermediate to high, people tend to go for cardiac CTA. But someone was asking about INOCA, MINOCA earlier. So sometimes you do cardiac CT, there's no significant obstructive lesions, but you still don't know the full diagnosis. Could this still be MI, especially with cardiac markers elevations? So the one advantage cardiac MRI has is to see scar pattern. And certain scar pattern will give you indication whether the patient has had myocardial infarction or myocarditis or pericarditis. So certain things you can gain from MRI, but not from cardiac CTA. And on top of that, of course, you can see myocardial ischemia as well. But it's not widely available. The cost is still an issue. So it's all discussion with the patients and availability and cost.
I think the other two questions can be very quickly answered. When a patient returns after several months with chest pain, won't you do an ECG first? Yes, obviously we would. Okay, I think they missed that, but they would do an ECG. If the calcium score is 0, does it require further investigations in patients with cardiac symptoms? If the patient has cardiac symptoms, yes, this is what they wanted to just show you. Could a stress echo could have picked up the abnormality rather than a stress test? Yes, the specificity and sensitivity is better, but again, it is not 100%. It is still less than 90%. TROP-T result, duration of result and any differential diagnosis. Choi, you want to say what are that means TROP-T result is positive. How long does it last for? And are there any other differentials besides just a myocardial infarction?
Yes, so very good question. Of all the cardiac enzyme markers, the first to rise is probably troponin. Especially nowadays, we have highly sensitive troponin. It can be as early as maybe 15 to 30 minutes, depending on the area of affected myocardium. The abnormal troponin will be there for at least about 2 weeks. So if you see the patient 2 weeks later, do not be too surprised to see the troponin being elevated. The question is whether any other cause of high troponin T. Yes, any kind of infarction or any stress, pulmonary embolism to some degree may also rise to elevated troponin T.
Chronic kidney disease can also cause, so there are a lot of other non-cardiac causes for raised troponin. So sometimes we also do a good old-fashioned CKMB as a counter check. What are the common causes of some of these ultra-fit runners who collapse while running? Kanan, would you like to answer that?
I think a lot of these ultra-fit people who collapse probably have one genetic diseases. They may have things like hypertrophic cardiomyopathy, which has not been picked up. They may have actually coronary artery disease, which has not been picked up. They may have congenital abnormalities of their coronary vessels. They may have arrhythmias, like long QT syndromes, which have not been picked up. They may have a family history, which contributes to coronary artery disease. So these are the things which are more likely as a cause of them collapsing. I think vasospasm by itself causing infarction can occur, but I don't think it's high up on the cards in these patients.
But I think a very common cause is that they have undetected significant coronary artery disease. Just because they run every day, they think they are healthy. But I think all of us have seen patients who actually think they're very healthy, but actually they've got very bad disease. So sometimes just using that as an assessment, symptoms alone sometimes doesn't suffice. If they've got a bad family history, usually they have significant coronary artery disease. Maybe I'll just take this last question. When you decide for CABG, is it depending on percentage, length, or number of obstruction? I mean, when would you decide for CABG versus PCI?
This one basically, there are some very clear-cut things. I mean, if you see left main stem disease, the vast majority of us will send the patient for bypass surgery, although angioplasty for left main stem disease is certainly being done. Triple vessel disease, certainly bypass surgery has got an edge over angioplasty. I mean, the more number of stents you put in, more price to pay down the road for restenosis and so on and so forth. Longer lesions, smaller size vessels, bypass surgery is going to be better as compared to angioplasty.
I think it also depends upon the surgeon. Some surgeons, you can have grafts which last for 30 over years, and sometimes it doesn't last so long. There are a lot of questions, but I shall defer some of it towards later as well. Choi has got a very short case that he would like to show.
My case is also a patient with no symptom, never had chest pain or any kind of effort intolerance before, came in after a stroke. So 57-year-old man with a background history of diabetes, poorly controlled. As you can see, the HbA1c is 10.5. For some reason, an angiogram, invasive angiogram was done before, 2014, and it was perfectly normal. He was admitted for a new onset of a stroke, and this case was referred to me because the referring doctor found out that the ECG seemed to be slightly abnormal. I would like to point out that if you look at AVL, I don't know what the pointer is. If you look at AVL, there's a bit of a T-wave inversion, but other than that, it seemed to me like a perfectly normal ECG. There's no real Q wave, there's good R to R progression, and a sinus rhythm. So at this point, what would you do? So I did a basic assessment that we could always order. Echo, normal left ventricular ejection fraction, normal valves, being a bit of high left ventricular hypertrophy. We did a routine cardiac enzymes, nothing elevated. And again, I went back to him and said, "Are you sure you're feeling all right?" He said, "Yes, I'm feeling okay other than the stroke. I've been walking up the stairs. I can even do my usual cycling. So technically it's NYHA class 1. What would you do next? Would you do some kind of imaging at this point? Maybe I get Dr. Kannan. to give a short comment.
So this patient is asymptomatic. To me, the ECG is normal. I won't look past it. So I probably would do nothing. He needs the usual risk control because of his stroke. His diabetes is poorly controlled. Do all those things first. Wait for him to recover. There's no urgency. And then depending upon the degree of physical recovery, if he's fit enough to walk, maybe a stress echo or maybe something more than that to evaluate for coronary ischemia, and then decide what we're going to do after that.
Okay, so that probably covers Dr. Sharma's question as well. So the thing is, the diabetic control and everything, luckily I have a physician on board, the neurologist. So I say, okay, I hand that to you. So she was doing all the work. Unfortunately, I'm not in favor of doing a stress test post-stroke because I'm just worried that if they get a bigger stroke, then I'll be liable for life. So what I did was, I did a calcium score for him. And it turns out to be 4. We had a bit of discussion about calcium scoring earlier. I would like to ask our calcium score expert, Dr. Su, would you still proceed with a contrasted CT angio given the low calcium score in this patient?
I think in this case, you have a low calcium score. It suggests that there is actually a low mortality or MACE from just being a low calcium score. Now, as we already alluded to, a calcium score of even 0 or 4 does not mean that there is no coronary artery sclerosis. I would still think risk factors assessment and symptoms would be the next stage to do.
Okay. At this point, would you give dye for the patient, for the CT?
No.
No, okay. So to recap, we have a patient who is perfectly well before this. High risk factor, obviously, diabetes, and not just diabetic, poorly controlled diabetic patient, came in with a stroke, also, vascular disease. To me, slight abnormal ECG changes, calcium score of only 4. Well, I gave contrast. So this is the CT scan. Just to make everybody get familiarized, this is the LED vessel. My pointer doesn't seem to work, but you can imagine that the long vessel is actually LED. And the proximal part of it seems to be hazy because there's no contrast filling up the artery. So this part seems to show something. Maybe Dr. Yap can give us a brief.
Yeah, I think if you look at the segment below, which is where the artery fills up well with the white contrast, it is quite clearly very different. So in view of that, the segment at the top, which is here, when you compare it to here, significantly much less contrast is coming through, and it's very likely that there's a lot of atheroma and plaque there. Again, we mentioned about calcium score. In this case, low, probably because there's just very minimally, just little bit of calcium, I think, on the side there within the plaque. So this is looks like a very significant stenosis of the LAD. No, we can actually do what we call QCA, quantitative analysis, but and that will give you also estimate. So in fact, what we find is that in practice, visually you can see the estimation a little bit better.
Yep. So at this point, we have a very important artery, the LED, at a very important area, the proximal LED, at a very important degree, severity of the stenosis in a very asymptomatic patient with a stroke. So, what would you recommend at this point? Unfortunately, we have done the contrasted CT and found this in a way. Open to the floor.
I think now we have no choice. You need to do an angiogram and do whatever is necessary after that.
Yes, I also agree. And in view of the severity, but unfortunately, because this patient is a freshly so-called stroke out patient, and he's actually asymptomatic, like what Dr. Kannan mentioned, the most important thing now is to stabilize his whatever diabetic control, put him on hydrostatin. He's already on antiplatelet, and he has no symptom. I guess he can wait. So I checked with the neurologist, and she said, well, I guess 1 or 2 months is fine. So After that, once it's more stable, with a bit of anxiety on board, obviously, after knowing his CT scan is so abnormal, we kept him. And this is the angiogram finding. And just maybe to follow up from the CT, Dr. Yap.
Yeah, in fact, not unusually when we do a CT and find a lesion, it doesn't actually give you such good resolution. And in this case, the angiogram is much clearer. And it looks much worse on the angiogram, I would say, than it looked on the CT.
Yeah.
So this is like almost 90-something% stenosis.
Maybe the anxiety contributed to that. So, like what Dr. Yap said, the invasive coronary angiogram gives us a better resolution compared to a CT. And at this point, my decision, I think it's a no-brainer, was actually to fix the artery, given the proximity of the vessel. And of course, we centered it, not to show off, but this is the end result of the angioplasty. Now, the thing I would like to highlight is that a month later, when I saw him back in the clinic, surprisingly, he mentioned to me that his effort tolerance has improved. Then I looked back at my notes and said, but wait, hang on a second. You told me that you had no symptom to begin with. Then he said, actually, you know, I actually had a bit of symptom. I always thought that I was just being old. So I'm quite glad that I made him young back again. So my learning points will be, number one, just to make it very clear across the board, not everyone with a stroke needs a CT scan. I did it for him because he has high risk, and in my opinion, his ECG seemed to be a little bit different compared to his older ECG that I seem to have in the folder. Well, no symptoms could be wrong. Sometimes, we probably have to ask the patients more specific and personalized questions like, do you cycle more often than before or less, and some sort. And always use a pre-test probability as a guide. And this patient's pre-test probability was very high. So I always thought that, when you have high risk, it's always worth investigating. Yeah. This patient, if not mistaken, they did an MRA, and not surprising, he also has vascular disease, vasculopathy as well in the cerebral arteries. But that is a very good question because, in this group of patients, it's not surprising that they could also be having atrial fibrillation. And if we don't fully investigate and we're not going to put them on the DOAC, he had a 7-day halter. The longest one could tolerate on the patch. Didn't pick up any AF or any significant burden of atrial ectopics. So that's why we did not think that it's embolic in nature. Any questions regarding this case?
Thank you very much, Dr. Choi. I think, of course, we can always argue in somebody who already has got significant cerebrovascular disease, high diabetes, a coronary CT may not be unjustifiable in this patient.